Hello, my name's Andrew Smith. I'm one of the orthopaedic consultants in the Trauma and Orthopaedic Department at QEQM Hospital in Margate. Our department's a relatively big and relatively busy department. We have 11 consultants. We cover the broad range of trauma and orthopaedics, so we have 2 hand surgeons, 2 shoulder and elbow surgeons. We have a team that carries out big joint arthroplasty, so hip and knee replacements. And we have foot and ankle surgeons. The parts of our specialty we don't provide here are inpatient spinal services and larger paediatric orthopaedic procedures. We're not a trauma unit, so almost everybody that comes from the trauma side of our work will have an isolated limb injury. In a year we deal with approximately 400 hip fractures, so that's a pretty big unit. So this is QEQ's ward. This is our elective orthopaedic ward, and it's where your patients that have had major joint replacement, bigger shoulder, bigger foot and ankle procedures will be looked after. This is our trauma floor with sea bathing ward and Bishopstone ward that look after our trauma patients. Our slightly older neck and femur patients are almost always looked after in Bishopstone, and the younger trauma patients are looked after on sea bathing.
Hello, I'm Martin Dagu. I'm the ward manager on Bishopstone ward, part of the trauma unit. I run a 22-bedded trauma unit for elderly trauma. In the main, they are fractured neck and femurs, and it is very much a multidisciplinary team that cater for those patients. We have an orthogeriatric team that essentially care for all their medical needs, but essentially I'm there to help you with all their orthopaedic needs, and my team are very happy to help you out in that. We expect you to check their bloods and write in their notes on a daily basis and give us clear plans of what is expected from you.
My name is Dr. Agnish Dutta. I'm a core surgical trainee in my first year, and I'm working in the Trauma and Orthopaedics department in QEQM at the moment. We start the mornings always with the trauma meeting, and that takes place in the trauma room. Here all the cases over the previous day and the night are discussed, as well as any cases that are remaining to be operated. So there's normally led by a consultant, and there's always a good learning opportunity in these meetings. We're always asked to interpret the radiographs or give our opinions on what management should be taken forward for the patients. So there's always a lot of quizzing, and it's always quite an interesting meeting. After the trauma meeting, we then there's a variety of things that may be done. Normally as a CT1, I'll do my own ward round. Maybe once, I look after the patients of 2 consultants, so 2 times in the week there'll be a consultant or registrar-led ward round. After this, it's up to the SHO really to either go and help and assist in trauma theatre, or go and attend a clinic, which is sometimes pre-arranged, help with an elective list as well. As per any junior doctor's duties, you will be prescribing medications, and in fact you will be doing a lot of the medical side of things, which the registrars and consultants especially won't help you as much with. So you have to take your experience from previous jobs to look after patients medically. Of course, there is an orthogeriatrics team who are very key in helping with especially the neck or femur fracture patients and the medical side of them. So you liaise with the orthogeriatrics team, and you also look after the orthopaedic side of things, but also help with the medical side, especially on on-calls. So the on-calls, I do one on-call every 2 weeks, and that's during the day, and then once a month I'll have a block of nights or a weekend or 2. It's usually given to us well in advance, and if we need to change it, we can, and we can swap. The on-calls are usually about 12 to 13 hours. The night on-calls are 13 hours from 8 p.m. to 9 a.m., which includes the trauma meeting, and the day on-calls are 8 a.m. to 8 p.m. The on-calls are reasonably busy, but not as busy as, say, a major trauma centre. We are well supported by our registrar and consultant if ever they are needed. They may be in theatre or preoccupied in some parts of the day, usually in the morning, but that's not usually a problem, as after they are free, they're easily contactable.
Going forward, we're planning on working on a resident medical officer programme, and this will mean that an agency will provide our basic level of care for our patients overnight, so that our core trainees don't have to work at night, therefore increasing their training opportunities during the day. They will still have to be on call, but only during the day, and that will mean that there's no time off after extended periods of night work. So I hope that going forward that will mean that the learning and teaching experience is better in the department.
Hi, I'm Janet Robson. I'm the Business Admin Manager for Trauma and Orthopaedics here at Margate Hospital. My office is on Bishopstone Ward, which is part of the trauma unit. I manage all of the doctors on calls, the rotas, and any requests for leave, study leave, need to come through me and my office. All the forms are here. We'd like 8 weeks notice. I forward all of the ward cover rota every week to the junior doctors. And we try and keep that the same each week so that you get to know the patients. But any problems, I'm here every day, 8 till 4. Just come round and see me. My door is always open.
Our training and teaching on an informal level occurs every morning at the trauma meeting, where all the cases that have presented to the on-call team the day before will be discussed, their management plans will be decided, those patients that are going to go to theatre that day will also be organised, and their teaching will occur around those cases. We're also very lucky in Margate in that we have a librarian that comes to our trauma meetings, so that if there's the latest research that we need to access to help plan our treatment, then Jonathan will arrange for that to be distributed the same day, and that's a very useful resource.
So aside from the trauma meetings, we also have recently started a weekly teaching schedule, which is SHO-led, and it's for SHOs. Sometimes consultants will give you a task to present an interesting case, and that can take place after a trauma meeting. These are not the only learning opportunities, however. Clinics, most of the consultants I've been with have always been very keen to teach. You can either sit in with them and watch a patient interaction, or you can go ahead and see a patient yourself and then present to the consultant. And then theatre opportunities, assisting and even performing some procedures under supervision is always a very good learning experience.
There's also formal teaching, and that occurs for the core trainees and SHOs in the department on a Friday lunchtime. That's organised by Mr. Vinny Icam, and that covers the basic general level of education for those trainees. The specialist trainees I teach on a Wednesday early evening, and that usually forms the basis of case discussions, either that I provide or that the guys bring along to discuss. For people starting at ST3 level, there's an indicative number of trauma procedures that you'll need to perform during the whole of your training. And the guys this year, with the change in timetable, our ST3s will have performed the huge majority of their indicative trauma numbers by the end of 1 year. So that's really pretty good. And those timetables have been adjusted to have an increased level of trauma care, and that's worked really well this year. It's a new way of doing things for us, but it has worked really well. So it is busy, but it provides the appropriate experience. For the core trainees, again, it is busy, and trying to balance the care of patients on the ward with getting operative experience is a bit more of a challenge, but it's equally, it is doable. And the guys on this rotation, again, with some changes in the timetables, have managed really very well. And again, they're getting good exposure to theatre, and they're getting protected time in clinic as well. So again, that's worked pretty well. Your educational supervisor will meet with you 3 times during our 6-month placement, so you should get plenty of feedback as to how you're doing, areas that you can improve on, and also discuss with us areas where we may be able to do things better for you. So that should be plenty of direct interaction, but if there's anything you feel you need to talk about or let us know beforehand, I'm responsible for the trainees in the department, and you can come and talk to me if you need additional feedback to us or additional help.
I think most of the consultants have a realistic expectation of you. It's quite a postgraduate topic. I have a key interest in it, so it's a different experience for me, but there are a lot who don't, have never done a rotation in trauma and orthopaedics before, but they have adapted perfectly fine. They're very well supported. It's a reasonably steep learning curve, but with the help of the seniors, it's quite manageable.
Our ward teams are very well established. They will help look after you. that most of them have been working in orthopaedics for an extended period of time, so they know pretty much how most things work. So if there's anything you don't understand, anything you need help with, our nursing staff on the orthopaedic wards are really good and they are really helpful, and they very much see you as part of the team, and it's very much a team effort looking after these patients. And going along with that, a lot of our older patients have multiple medical problems, and the neck of femur patients are helped looked after by a team that includes an orthogeriatric physician team, of which there are 4. So there's plenty of help there, and indeed they probably will spend most of their time looking after the medical problems with those patients, and that shouldn't be a big problem for you.
Nurses have developed their roles to work within the team and support the doctors as well. It's a very cohesive, multidisciplinary team consisting of physios, therapists. The nurses developed their roles to enable them to actively participate in the discharge of patients. So that enables us to very much support and work together with the doctors, our medical colleagues, to discharge patients safely and effectively in a timely manner.
Hello, I'm Terry Humphreys. I'm one of the orthopaedic sisters in main theatres. You will see me probably in the trauma meetings as well as the team meetings in the morning for both the lists, orthopaedic elective lists, coordinating what's happening between theatres and the surgeons, what they decide to do on a daily basis. It's important that you approach us when you need support or you want to ask any questions about what instruments you need, what kit you might need for the patients of the day. We are here to see you through the department, from teaching you how to wash your hands, what to wear, where to go, what to touch, all the little things that you will need to know coming into a different environment, which can be very noisy and very loud. But don't be put off by that. That's what we're here for, is to help you through the department.
Yes, I think make yourself known to the team. Your input is just as equal as the physiotherapists, the occupational therapists, the sisters on the ward and the nursing staff, and really there's a huge number of team members that you will find will get involved. Just make sure you're introducing yourself. Communication is absolutely key, so documentation, face-to-face interactions. If you need to relay a message, then it's best to do it face-to-face, and everything should run quite smoothly. I have some general applications that I use. For example, the BNF is always very helpful. Other than that, I would advise that whoever's coming to work in the department familiarises themselves with the relevant software. That's absolutely key in trauma and orthopaedics, with imaging being such a central part of it. So make sure that all of that is ready for when you're starting your job. So far it's been quite good. The staffing has been reasonable, which means that the consultant cover and the ward cover hasn't been too taxing a job, which means that there is more time to access clinics, go to theatre, and really take a lot from those opportunities.
So we're really looking forward to welcoming you to the team and seeing you here in Margate in the not too distant future.